Hi guys, it's Dr. Grundon here. We're going to go on and start with some of our PowerPoint recordings on some of the topics that you guys are going to need for school. As you see, we're going to start musculoskeletal. I'm going to try to get osteomyelitis and compartment syndrome on one taping, but we'll see how far it goes. So again, osteomyelitis is basically, it's an infection in the bone. It usually starts from an injury surrounding in the tissue that goes into the bone, such as crust injuries and stuff. One of the most common causes of osteomyelitis is the Staph aureus infection. And you can see right in here, this is osteomyelitis, this is some osteomyelitis, this is severe osteomyelitis, and severe osteomyelitis right here. So osteomyelitis infection is of the bone. 21.8 in 100,000 people will get the osteomyelitis. It's higher in men than women. I'm not sure why. I don't know if it's because men typically don't want to seek medical care as quickly as females do. I'm not trying to be, sexist or weird or stuff. It's just a fact. But we do tend to see that men will get this problem more so than women. It's hematogenous, developed from bacteria in your bloodstream. Meaning is that you get a crush injury or you smash your finger or something happens and you get it, or you have some kind of immune problem. It's a continual focus. Usually you can't, a contiguous focus is that you've got it because you had surgery, and during surgery somehow or another the bone got contaminated. They didn't use good sterile technique or something like that. We also get this in vascular insufficiency, and again, more than 50% of these cases are from Staph aureus. Healthy bone, if it's healthy, it doesn't want to be infected, so it's really resistant to infection. But if it's large amounts of bacteria, it loses its blood supply, whether to compartment syndrome or swelling or something, or a presence of a foreign object that the bacteria is living on. So you get a piece of metal in your hand or finger or foot, and it's got bacteria on it, and you don't know it sets in there. It can actually cause osteomyelitis. Hematogenesis usually means that children, their long bones get it, adults in their vertebrae. A lot of older adults will get osteomyelitis in their lumbar area of their back. Younger adults, this we see more trauma and surgery, and of course elderly, believe it or not, when we have pressure injuries, especially in the sacral area, they will actually get osteomyelitis because of the pressure injury and infected joint replacements. Now, one thing I want to do is that I did want to say there was a case that there was a woman who had osteomyelitis of her lumbar spine that was in Houston, Northwest for 3 straight months getting IV antibiotics. It was miserable for her. It was miserable for the nurses because she did not want to be there. So it does take a long time. And she actually had a comorbidity of diabetes, which made it harder to fix. So risk factors, of course, diabetes, sickle cell disease, HIV or AIDS, any kind of rheumatoid arthritis, IV drug users, because IV drug use decreases your immune system, alcoholism, that liver, if it's damaged, it can't get rid of all the bacteria. It can't act as a filter that it's supposed to be. Long-term steroid use, we talked about avascular necrosis of the joint or the hips and stuff. Hemodialysis, circulation, of course, any kind of recent surgeries. Children, again, we went through with the long bones of the legs and upper arms, the adult spine, and diabetics, it's the feet, because they can't feel the injury there because of neuropathy. So they can have, I've actually taken care of a man who had a tack in his foot for like 4 months, and when he finally came in to see me, I took off his foot, and biggest day, there is a tack embedded in this nasty, oozy wound, and he's like, I never knew I had it. So it's very important that we look at our patient's feet. Acute osteomyelitis is often seen in children. So what happens is they have some other kind of infection, they have a small minor trauma such as they smashed their finger in the door or something like that, but then the bacteria and stuff chooses to go to this area and causes, as what we know, acute osteomyelitis. Chronic osteomyelitis is basically a primary soft tissue infections such as pressure injuries or decubitus ulcers or an infected surgical site. So there is a bone with osteomyelitis. You can see it all in through here, how this bone is just eaten away with infection. This person will probably have this cleaned out and put some antibiotic irrigation, but they stand a big risk of losing this leg. All right, so signs and symptoms. Well, fever and chills. Those are primary signs of any kind of infection. Irritability. When you don't feel well, you're irritable. Fatigue, of course, because the body's fighting off the infection. Pain in the affected area, unless you're a diabetic who has no sensation in their feet or lower extremities. Swelling and warmth. These people, if it's near a joint, they'll lose the range of motion of the limb. And that's actually swelling, not swelling. I apologize for the typo. Of the feet, legs, and ankles, especially if this is in the lower extremities. In some cases, you might not have any signs and symptoms of it. It might be there, and it's an incidental finding on x-ray or something. All right, so how do we find out? Of course, x-ray. But an x-ray may or may not show any sign. Remember, x-rays are only going to show signs if damage is already done. If the infection is new and the bone has not been damaged, then x-ray is not going to pick it up. Bone scans in these areas, you can get a little bit more of what we call of a highlighted area. That could also be osteoporosis, but it would be something that they would be interested in looking at more. MRIs, needle aspiration of the bone, of the joint or the bone to see if we can get tissue and culture it to see if there is infection in it. A WBC tracer is actually done in nuclear medicine and radioisotopes where they inject it in, and it's supposed to, this tracer is supposed to actually go to an area of osteomyelitis if you have some. And of course, blood studies, CBC, SED rates for inflammation, blood cultures, and C-reactive proteins are more specific for systemic inflammation than we see with SED rates. Treatment, well, drainage. We're going to open that wound, that area up, and we're going to drain it if there's an abscess. We're going to give them antibiotics for at least 4 weeks. Multiple antibiotics. These guys are not going to get one. Oral antibiotics do not usually work on this. We either have to give them through IV, long-term IV, or we do an antibiotic irrigation to the bone itself. But although some people say, well, it's new, let's give you oral meds. But if it is a long-standing, especially chronic, it is long-term antibiotics because osteomyelitis does not like oral antibiotics. Of course, surgery to remove the infected tissue and bone if able, and if not, amputation of the limb. So what are we going to do? Well, we want to question the patient about previous trauma, open injury, surgical procedures. Have you had anything done in the past few months? Remember what I said, if you have, in one of my slides you'll see later on that I said that if you had a joint replacement and you get a staph infection 10 years later, that staph infection will travel to that joint and cause another infection. We look for chills, tachycardia, diaphoresis, fatigue, of course, redness, swelling, pain, open wound. We always look at the heart because our heart elevates because our body keeps saying we need more blood to help fix this. But if there's no circulation, the faster or harder your heart beat's not going to help. We worry about respiratory because if it becomes septic, we can go into some respiratory failure, and we always inspect the skin carefully. We want to control the infection, and we always want to worry, do we have a secondary infection such as a pneumonia from the osteomyelitis? Bacteria likes to travel. They get tired of being in one spot. You know, mom and dad grow bacteria, get there, they have baby bacteria get tired of living with mom and dad. They take off down the bloodstream highway and say, oh, hey, here's the lungs. I like it here. Let me set up here and have my own family. Then you have a respiratory infection. We want to make sure we control their pain. We use aseptic technique when changing the dressings and performing wound care because we don't want other infection to happen. Meticulous skin care assessment and care. We have to really take care of these patients' skin. Range of motion of the joints because we don't want to lose a joint. Remember, if you don't use it, you lose it. And once you lose it, you don't get it back. And of course, education, medical management, that this is not a short-term 14 days of antibiotics. This could be 3 to 6 months of antibiotic IV at home. Lifestyle changes. If they're diabetic, they need to be able to take care of that limb. They need to inspect their feet. And of course, if they do go home, and they will probably go home with a PICC line and home health, then we need to know how to manage that PICC line at home, how to bathe with that PICC line at home. What are we going to do for this? So some nursing diagnoses, of course, acute pain. If it's in the lower extremity, impaired physical mobility, risk for further infections, and of course, risk for more secondary impaired skin integrity. So this is short and sweet for osteomyelitis. If you have any questions, just email me or you can text me. Make sure on the PowerPoint you look at my notes pages because I have put notes in there. The next topic will be compartment syndrome.